course. The first topic is on superficial anterior lamellar keratoplasty, and we will play Dr. Pravin's recorded talk.
Hi, good afternoon, and my sincere apologies for not being able to be here in person to speak to you about superficial anterior lamellar keratoplasty in this amazing course that Dr. Rajesh Fogla has put together. But I'll try and do my best to share with you some of my thoughts in superficial lamellar keratoplasty in the next 8 to 10 minutes or so. Hope you have a great conference, and I hope to see you tomorrow, which is when I'll be at Cochin. So the kind of patients who might benefit from superficial anterior lamellar keratoplasty, which is called SALK for short, to differentiate it from the deep anterior lamellar keratoplasty or DALK, is a surgery that is limited to the anterior stroma of the cornea. So technically, any surgery that does not reach up to the desmase or the predesmase layer can potentially be called SALK. But in general parlance, SALK is referred to surgeries that are limited to the anterior 300 microns of the corneal stroma. So it is useful or beneficial for people who have pathology in the anterior 300 microns of the corneal stroma. So includes corneal scars, degenerations, and some dystrophies as well. So before we actually look at where SALK is going to be beneficial, I think it's important to explore the various options that patients who have superficial corneal lesions might have. And this is based on the kind of corneal lesions they have. So you have corneal lesions like in dystrophies that might have a surface that is smooth, or you might have lesions that are slightly elevated or extremely elevated like in spheroidal and in Salzmann. So what actually will benefit which patient is the goal of the next couple of slides. So the two different kind of lesions that you have on the cornea can be categorized into lesions that are non-elevated, and these are lesions that have a smooth epithelium in spite of the opacity being irregular, and this happens over time because of the amazing potential of the epithelium to smoothen the surface of the cornea, and can also be imaged by topography to look at, to identify the amount of smoothness or irregularity on the surface. The second kind of lesion is the elevated lesions of the cornea, and the typical prototype of this lesion is Salzmann nodular degeneration, and you have a lot of lesions on the surface of the cornea, including scars on the anterior surface that will fall into this bucket, where SALK is a great option. So how do you differentiate, and how do you choose which surgery will be most beneficial for which patient? If you have a lesion that is non-elevated, that is, it is flat on the surface, versus a lesion that is elevated, for non-elevated lesions, you have to again differentiate whether the epithelium is smooth or not. So non-elevated lesions, you can identify on slit lamp examination. If the epithelium is smooth or irregular, you can identify on topography. Now, if you have the epithelium that is smooth, the ideal surgery for this kind of lesion will be a transepithelial ablation and then to do a PTK after this one, which will help in removing the lesion as well as smoothening the surface. In case you have an irregular epithelium, you can debride the epithelium and then you can do a PTK using a masking agent. These are for non-elevated lesions. And again, the typical example of a non-elevated lesion is a patient who has post-PRK haze, as you see in this example, where though the haze is irregular with a sawtooth kind of appearance, the epithelium is smoothing it out and making sure that the topography is regular. These patients do really well with a PTK because the lesion is relatively anterior stromal and the surface is smooth, so a transepithelial PTK is a great approach, and you can remove the lesion in its entirety. We won't be going to the details of this, but that's for another day. Now compare that with elevated lesions on the surface of the eye. This is a patient who has a localized Salzmann nodular degeneration, and the ideal surgery for Salzmann is just to peel the lesion off the surface of the cornea. Most cases, the Salzmann lesion is on the surface, and you can remove it without too much disturbance of the surface of the cornea. And if you have significant scarring or irregularity, you can even do an AMG if you would like to in these corneas as well. But this is an example of the same patient that you saw in the first slide, where the Salzmann has been removed just by peeling off the surface of the lesion. What do you do when you have denser lesions that are slightly deeper in the cornea, which might not be amenable to PTK, might not be amenable to also scraping or removal of the surface? Well, you have alternatives, and these include mechanical debridement, which is useful in some cases of spheroidal, some cases of anterior variant of the superficial variant of the granular corneal dystrophy. But you also have SALK, femtosecond ALK of FALK, and DALK. Now, ALK can be done either with a microkeratome or can be done using a manual method. And I think Dr. Namrata Sharma is going to be speaking about microkeratome-assisted ALK. And you'll see that in the subsequent talks. But the problem with microkeratome-assisted ALK is the fact that if you have a surgery done for a lesion, typically you'll need to place sutures. And the reason why you need to place sutures is because you might have a mismatch either in the diameter of the graft, or you might have a mismatch in the thickness of the graft, which is the reason why you'll need sutures. The other interesting aspect of a microkeratome-assisted ALK is if you have an irregular corneal surface, then you will replicate a little bit of that irregularity onto the bed as well. And so the topography is, if it's irregular, you're going to have an irregular topography after you do a microkeratome-assisted ALK as well. Now, one of the variants that has been described has been FALK or FALK, where you can do the same kind of surgery, but with a femtosecond laser. Now, the big advantage with doing FALK with a femtosecond laser is the fact that because the mismatch of the diameter is so minimal and the edges of the flap that you create are so vertical, you can effectively place the corneal tissue that you harvested from the donor onto the bed and leave it in there to stick just like you would do a LASIK flap, and you don't require sutures in this kind of situation. So this is a case where there was a corneal scar, and then the corneal scar is being removed after the femtosecond laser has created a cap, and after that has been removed, you will see that we will replace this with a corneal cap, which is cut to the exact same diameter, and you'll see that the cornea appears very clear, and you don't require sutures for this, which is probably one of the biggest benefits of early visual rehabilitation. Now, FALK, though it sounds really good, if it's used for eyes in whom the surface might be slightly irregular, like you have in granular corneal dystrophy, you will have very good outcomes because this is post-FALK and the recurrence rates are pretty low as well. And this is a great option. But if you use it for patients who have an irregular corneal surface, like you see on the corneal scar in the picture on the top left, preoperatively, postoperatively, anatomically, it looks great. It looks like the scar is completely gone and you've got a great outcome. But if you look at the OCT below, you'll see that the bed is actually quite irregular. And this is because of the fact that the surface of the cornea was quite irregular as well. And so the surface irregularities are sort of copied or xeroxed onto the bed, and you will have irregular astigmatism in these cases too. So the other issues with femtosecond anterior lamellar keratoplasty is the fact that the deeper you tend to go, the more irregular the cut becomes. And so if you have a opacity that is in the anterior 200 microns, you'll have good results. But if you have to make a cut that is deeper and deeper because the laser has to traverse to a greater distance, you'll tend to have more irregularity in these situations. So very quickly, I'd like to share a case with you where we did femtosecond assisted anterior laminar keratoplasty. This is a patient who had microkeratome LASIK and then epithelial ingrowth, underwent debridement and flap lift and removed the ingrowth a couple of times, but the patient had recurrent ingrowth and the ingrowth was quite deep. And since the surface was quite smooth, we decided that we're going to be doing an FALK for her. And the FALK worked out pretty well, and this, you see, anatomically had a great outcome, and the patient was relatively happy. Obviously, you'll see that the bed again is a little irregular, and you can see that Bowman's as well on the surface is slightly distorted, so the patient actually required contact lenses for good vision. It's another matter that we were able to do a topoguided PTK and then a PRK later on for her, and then she achieved an uncorrected vision of 20/25, but that's several interventions. So FALK, to summarize, is a great option in anterior stromal scars and in lesions that have regular corneal topography. If you have denser opacities, it's a little more difficult to do. and you will have issues with interface irregularity and sometimes residual haze as well. Very occasionally, you might have sizing issues, but the majority of times this can be a sutureless cell. The biggest advantage of FALK is that you have early visual rehabilitation. But coming back to the original topic of our discussion of what do you do when you have elevated lesions on the surface of the cornea. We saw that when you have non-elevated lesions with a smooth topography, we will actually do either, you have to evaluate if the lesion is less than 100 microns deep from after the epithelium, then you will do PTK. If it is greater than 100 microns, then the preferred surgery will be a FALK or even a microkeratome-assisted ALK. This is only if you have smooth topography. But if you have irregular topography, then and if the lesion is less than 250 microns, then LK or ALK or SALK is a great alternative. If it is irregular and the lesion is deeper, you might actually be better off doing DALK as well. So now, where does this fit in? You see that superficial anterior lamellar keratoplasty.
We'll pause at this because his presentation is still a little longer. It covered the aspect of superficial anterior lamellar keratoplasty.